Good morning. I am Dr. Luis Michea, MD and PhD by training from Universidad de Chile in Santiago, Chile. And I'm here because I want to present you some new biomarker for diagnosis and prediction of acute kidney injury and also outcomes of this disease. Acute kidney injury is the rapid decrease in renal function. It's it is frequent, has a 15% incidence in hospitalized adults, and more than 40% of patients in the intensive care unit will suffer of acute kidney injury. It is a global problem. It is deadly, 20 to 40% of mortality. And also, if you survive, you will have the chance of having a chronic kidney failure. One in each of 4 patients will have a chronic kidney disease after 1 year of the acute kidney injury episode. AKI is expensive for all the healthcare systems. It's getting more frequent, and the mortality is increasing, even though the intensive care units are, I think, better than 20 years ago. So this is a very big problem. And the main thing is that we don't have a good method for diagnosis. We normally use serum creatinine levels, absolute or relative increase, but this is a poor biomarker. It is slow. We need 24 to 48 hours to detect an increase in creatinine. It is non-specific and could be affected by many of the, let's say, demographical and physiological variables in patients. So there is a need of some better methods for diagnosis to improve all these problems and outcomes. Based on our previous studies in several animal models and some small studies in patients, we would like to propose a new biomarker formed by these 3 proteins, FGF23, erythropoietin, EPO, and clotho. EPO is the physiological sensor of kidney hypoxia, and it is released when the kidney has lower levels of oxygen. Clotho is produced by the distal tubular cells and also decreases when there is any tubular damage. And FGF23 is produced by bone cells and rapidly increases after kidney damage in our experiments. So we did several studies. I will show the main evidence. This is the first one we did in patients in our hospital. We took patients just after they were derived to the ICU and took a blood sample and all the data to test if our biomarker could work or not. We measured FGF23 and EPO levels in patients with and without AKI, acute kidney injury. So here are the results. You see that the patients that have a AKI 24 to 48 hours later showed increased levels of FGF23 and also EPO, meaning that this could be a good marker. We did a second study. Now we have more patients, 164. Also, they were admitted to the ICU, and at that moment we took the blood sample. We have patients here with acute kidney injury, without acute kidney injury, with a acute kidney injury after 24 or 48 hours, or that presented AKI at the admission, okay? And all the patients had the diagnosis of sepsis or severe septic shock. We measure how the biomarker performs and also the clinical outcomes. And here you see this is our biomarker, the 3 molecules. Patients without AKI, low levels, lower than 1. This is a logarithmic scale. But if you have AKI at the moment of IQ admission or 48 hours, your levels will be much higher. Also, the biomarker levels correlate with the severity of acute kidney injury. You see the higher levels are in patients with the more severe damage. And if you look here, we compare, this is the ROC analysis. This is a creatinine, the traditional one, and this is ours, much better. We separated the patients according to those that have had a low levels of biomarker or high levels to see if we can separate according to diagnosis and prognosis. And you see this is mortality after 30 days. Blue are low levels, red high levels of the biomarker. And we can separate, you see if you have a high level of the biomarker, your mortality is higher. And if you look at to the other outcomes, this is vasoactive drug requirement, renal replacement therapy, mortality, and development of chronic kidney disease after 1 year. If you survive, your odds ratios are pretty bad when having this biomarker high. So in sepsis, this is working fine. Sepsis is important because it's a more challenging clinical scenario for any kind of these biomarkers for AKI. So next we did this study. We have now a 3-center study with 280 patients. We did a similar design and we measure our biomarker compared to the currently available biomarkers for acute kidney injury. So in here is the performance of the biomarker. We compare to NephroCheck and NGAL. You see that we did the two commercial ones. We have a 2.1 increase and 1.8 increase. However, ours has a 4.1 increase and we believe a better separation. This is the ROC analysis for AKI prediction, NephroCheck, NGAL, ours. And here is the summary. You see we did better than NGAL and similar to NephroCheck. And here is the life support therapy prediction capability of the biomarkers. This is NephroCheck, NGAL, and ours. And you see that we can predict much better the need of life support therapy. This is the summary, and those are the numbers. Finally, if you compare, you analyze the outcomes in this cohort, we have many kinds of acute kidney injury patients, and you will see that these are the old ratios. If you have a high biomarker, your future is really bad. You see higher possibility of requiring life support therapy, higher mortality in hospital and also after hospital. So we believe we have a very good biomarker, better than the ones we have already in the market. It works in sepsis and also in other settings of acute kidney injury. This is the history. We have a grant from our government that pay for many of these studies. And this grant can have the possibility of a second grant to build a prototype and test it. So we are here looking for a potential partnership with somebody that could be interested in to participate with us in this grant, presentation, and to further develop this prototype and the biomarker. Thank you very much.
We have time for one question. One question, Patrick.
Hi, nice one. What is the method for the assessment and how stable is your FEK biomarker in the blood?
The biomarker molecules have a relatively short half-lives. It didn't show the data, but mainly in the first couple of studies we measure, and it goes down after, in patients, 2 or 3 days of the peak value of creatinine, meaning that somehow it's informative of kidney recovery too. I'm sorry? It is a plasma sample, and we use antibodies for yes, so the prototype should be, let's say, a point of care ELISA kit or something similar.